Thank you, everyone, for joining us. I'm going to do a quick introduction of Mr. Watts and just a few logistical things and welcome you all to the first session of the Windy City Warmth Spring Conference, Doubled Up, Reframing Homelessness in America. Tonight's schedule, we will be having Mr. Watts speak for most of tonight. We'll be having him do a 20-minute speaking portion, and then there'll be a Q&A time as well. So during that time, if you have questions for Mr. Watts, please feel free to put them in the chat. We'll make sure to get as many of those questions answered as we can. So one of the reasons we want to be discussing government action and housing insecurity is because for those of you who might not be in the fields much or might not know as much about housing insecurity, it is greatly affected by the work that the government does and the work that the government does not do. And there is a history of government action deeply affecting how our communities and our neighborhoods are either housing secure or housing insecure. Whether that's redlining in the 30s with the Homeowners Loan Corporation, or whether that's in 68 when the Supreme Court made that illegal, or the fact that there's unfortunately still a lot of in practice redlining and other such things still alive today. So this is a really important topic. We are beyond blessed to have Mr. Watts here tonight to speak. Just to give a quick introduction of Mr. Watts. He's the Chief Executive Officer of the National Healthcare for the Homeless Council, which supports the 300 federally funded healthcare for the homeless programs and 100 medical respite providers with training, technical assistance, sharing of best practices, research, publications, and an active policy and advocacy program working to eliminate homelessness. Bobby has spent 30 years of experience, or has 30 years of experience in administration, direct service, and implementation of homeless health services, beginning as a live-in counselor at the New York City Rescue Mission. He spent most of his career prior to joining the council at Care for the Homeless, which operates clinics, shelters, and conducts policy analysis and advocacy in the New York City, beginning as an intern and serving as the executive director from 2005 to 2017. Under his tenure, the federally qualified health center agency tripled in size, adding major programs and initiatives, including constructing and operating a shelter for 200 mentally ill and medically frail women, and becoming licensed as a diagnostic and treatment center in New York State. He has served on numerous boards, government-appointed task forces, and work groups, including serving as the finance officer for the New York City HIV Health and Human Services Planning Council, on the New York City Department of Health Medicaid Redesign Team's Affordable Housing Work Group and Value-Based Payment Work Group, on CBOs and social determinants of health, and as an inaugural member of the New York State Interagency Council on Homelessness, where he co-chaired its health committee. In February of 2021, he was appointed as a member of the Biden-Harris administration's COVID-19 Health Equity Task Force. So a little bit longer than a brief introduction, but for someone who's an incredible person who's spent many years in the field, and we are honored to have him. Thank you so much, Mr. Watts. Feel free to share your screen.
Thank you. I will. So while I'm doing that, first I just want to say the honor is mine to be here with you for your inaugural conference. And really my hat's off to you, James, and your teammates for starting. It's always hard to start. And now you are providing services and also education and to think that you are college students, or at least you are still a college student, and you are all to be commended, and I'm really honored to be here with you. So I want to cover a few things. I really like the title of your workshop, the conference. It's Reframing Homelessness in America, with the emphasis on people who are doubled up. And I really like the idea of reframing because things have changed over the years, but oftentimes I would be a guest lecturer in college classes, and I would ask the question, why are people homeless? And generally, almost uniformly, I would get questions. The answers would be, they don't have a job, they don't have poor education, they have mental illness, they are addicted. Um, um, and more in the last few years, people have moved away to giving those answers, which are in part correct, to a more complete answer, which is looking at our systems. How in the richest country on the earth can we have homelessness of this magnitude when other wealthy countries don't? That implies that it's not a problem with the individuals as much as it is a problem with our systems and our structures. So I'm going to share my screen in just a second. And then we will begin. So here we go. So I want to cover a few things. First thing is, want to tell you about my organization, the National Healthcare for the Homeless Council. And I like to start by looking at our mission statement, which is grounded in human rights and social justice. The National Healthcare for the Homeless Council mission is to build an equitable, high-quality healthcare system through training, research, and advocacy in the movement to end homelessness. We went through a strategic planning process a few years ago, about 2 years ago, finished it around 2 years ago. And one of the outcomes was this new mission statement. And there are a few reasons why I really like it. First one is that it states right up front that we are concerned about human rights. We view healthcare and housing as human rights, and working to secure those rights for people is a matter of social justice for us. And we want to not only have a healthcare system that is high quality, but it's also equitable. And I really believe that you can't have high quality care if it's not for everyone. High quality care for some is not the high quality healthcare that we should be providing. And the main ways we do that is through training, research, and advocacy. And our ultimate goal is to work to end homelessness. And we know that we can't do that by providing direct services only. We need to do that by changing some of the societal systems that are producing mass homelessness on this scale. And we know as an organization, we can't do that by ourselves. So it's part of a larger movement to end homelessness. So just the National Healthcare for the Homeless Council, we support healthcare centers and medical respite programs. We have about 200 organizations that are choose to pay dues as members, but we provide services to everyone. What powers us is those on the front lines. Everything we do is informed by, so that helps to make sure that it's relevant. It's informed by the clinicians, the doctors, nurses, social workers, administrators, advocates, and most importantly, the patients that are seen in the Healthcare for the Homeless clinics and medical respite program. Our term is consumers, but they are on our board of directors. They are on every board committee. So they are my boss. And our goal is that in each of the 300 Healthcare for the Homeless programs, they would have vibrant ways of ensuring that their services are informed by those that they are serving. We say in business that the first rule of business is to listen to your customer. And I will say in human services, homeless services, and in healthcare, we do a really poor job of listening to those that we're serving. So the council really takes that to heart and really want to place at the center of those with the lived expertise of homelessness. So reframing an understanding of who is homeless in America, who's experiencing homelessness. This is from the most recent January 2020 point in time count, which is done all over the country in the same week, generally the end of January or very beginning of February. And the data is compiled by the Housing and Urban Development arm of department in the federal government, HUD. And been going on so we can look at trend data. So the first thing is to look at is to see in the first one under housing status, we see that most of the people who were found in one night or were estimated to be experiencing homelessness on one night in January 2020, about 70% of those were in sheltered and 30% were unsheltered, living outdoors on the streets, in parks, in encampments. And we also see in the one on the right, the pie chart on the right, about 39% are female, and about 40%, excuse me, about 60% are men. In the one in the middle, with looking at race, we'll see that the largest portion are people experiencing homelessness in this point in time. The estimate were whites, about 48%. African Americans were 40%. Native Americans were 3%. And we're going to talk about that because most people of color are wildly overrepresented in who experiences homelessness in this country. So for instance, African Americans make up about 13% of the population, but 40%. Native Americans make up about 1% of the country, of the population, but about 3% of those experiencing homelessness. So both are overrepresented by a factor of 3. Now, when you talk about who is homeless, a big part is how do you define it? So what I just showed you were numbers that showed 580,000 were homeless on the very top. You'll see that. That's the estimate on a given night. So are you talking about people experiencing homelessness on a given night, a point in time, or over a course of time, over a period of time, like a year? So we know with a fair amount of certainty that most years, 1.4 million people live in shelters in the course of the year. And according to the Department of Education, about 1.4 million school children experience homelessness in the course of a calendar year. And so what's different, we have to look at a point in time versus those who experience homelessness in the course of time. Now, that's one thing. Now, the other thing is looking at the definition. And even in the federal government, there are multiple definitions of what is considered to be a person that is experiencing homelessness. So the one that most of our health centers and most of our health centers are concerned with is one from the Health and Human Services Department. And that's a much more expansive definition than the HUD definition on the bottom. And these are just summaries of them. The biggest difference is the Health and Human Services recognizes that you could be doubled up. That meets the definition of experiencing homelessness. You could be in a single room occupancy. You could be in supportive housing. You can just have been released from prison or hospital with no place to stay. Even among the federal government, you're going to get different definitions, and therefore you will get different counts of how many people have experienced homelessness in the course of a year. So I want to speak very briefly about homelessness and health. And in general, homelessness and health are highly correlated. Poor health can lead to someone falling into homelessness, and experiencing homelessness can worsen your health and make it harder for you to recover your health. The number one cause of personal bankruptcy in this country, and it's been this way for 40 years with one or two exceptions in the great financial meltdown of 2008 and 2009. For 40 years straight or more, it's been medical expenses has been the number one cause of personal bankruptcy. So we can see how poor health in our current system of how we finance and provide healthcare can lead to bankruptcy, loss of home, homelessness. On the other hand, and I saw this when I was living at the rescue mission and in my many years of operating a healthcare for the homeless program, seeing people who newly fell into homelessness and saw what the effects of not having a stable place to live, living on the streets, uh, does to one's mental health, to one's physical health. So the fact is, and this has been, studies have been fairly consistent for the last 20 years or more, and even internationally, that people who, the average age of death of those who are living unsheltered is about 20 to 30 years younger than the average lifespan in the US. So right now, the average lifespan in the US is about 78 or so. It actually will go down this year because of COVID, but roughly in that neighborhood, around 78 years. And the average age of those who die on the street is late 40s to early 50s. So it's about 30 years less. And this is, again, this is also true internationally. So there is something that is extremely stressful, you're exposed to the elements. It's harder to get care. It's harder to get any condition successfully treated if you don't have a stable place to live. And so we see a high correlation between mental illness and substance use with those who are experiencing homelessness. And it could be easy to conclude, oh, so therefore the mental illness, the reason they're homeless is because they are mentally ill. Or the reason they're homeless is because they have an addiction. But the fact is that most people with mental illness are housed. Most people who suffer from a substance use disorder are housed. So yes, it is a cause, but it is far from the total explanation, and probably total from the far from the most important explanation. So let me just say something about the healthcare for the homeless programs, because you have some in Chicago. So I want to say just a little bit of what they are. All of them are federally qualified health centers, meaning they have to meet really strict standards of care. There are 1,400 federally qualified health centers. 300 are a subset that get special funding to focus on people experiencing homelessness. Those 300 served over 1 million patients throughout the country. There's at least one at least one healthcare for the homeless program in every state. And these are comprehensive services. In addition, the healthcare for the homeless programs have to provide or have a really strong linkage to mental health services, substance use disorder, and they have to do outreach in some way. Some do outreach by putting clinics in shelters or in soup kitchens. Some do it by practicing street medicine. Some do it by having a mobile health clinic that travels. Some do it by building a clinic in an area that's frequented by people experiencing homelessness. So those three special characteristics and requirements are not for the regular community health center FQHCs, but for the healthcare for the homeless programs. Have to do mental health services, substance use disorder services, and have to do outreach in some way. We are very much important. One of the things from the very beginning, and the program started in 1985, so it's been around for 35 years. And I like to say the rest of the healthcare system is catching up to the healthcare for the homeless programs. From the very beginning, we knew we had to provide whole person care. We can't just treat someone's physical illness if they don't have a place to live, if they're suffering from mental illness or substance use disorder. We have to treat their whole care, find a place for them to stay, help them get their lives together, not just bandage them up. So we've always done that. And one of the key things is we've always been practicing trauma-informed care, even before that was a term in the popular medical field, or that is now popular in the medical field. And in short, what it does, it's realizing that everyone who's experiencing homelessness, and many people in poverty and in stressful environments, experience trauma, which has wide-ranging effects on their mental health, their physical health, their social health. And that as providers, we have to be careful. We have to let that inform how we care for them, so that we are not doing something that will exacerbate their trauma by our policies. I wish I was aware of this when I was at the rescue mission, because many of our policies, yes, they helped us keep the things going smoothly, but they were really counterproductive. And we did not need to have some of the rules that we did. One of the principles of trauma-informed care is that we understand that trauma takes away autonomy and control from an individual. So we want to, where possible, give them choices, give them control back. So one concrete example of trauma-informed care in practice. My former agency, we operated some shelters. The last one we built while I was there was to be a bed for, 200 bed shelter for mentally ill and medically frail women. So we had focus groups with the residents of a shelter we were operating at that time before we built this one. So if we could start from scratch, what could we do differently? And they told us a few things. We couldn't do all of them, but we were able to do one of them. One simple thing that made it a huge difference to the women was, according to New York City, which funded us, there's a lights out have to be, every light has to be out in the dorm rooms at a certain time, about 20 to 30 women in each dorm. Lights had to go out, I think it was 10. And that was really upsetting. You know, people would say, I'm in the middle of reading, I'm trying to sew, I'm trying to do this. I'm got to turn the lights out. So we listened to them before we built it, and we built into the walls, some lamps that shone just on each woman's bed, so it wouldn't disturb anyone else. So we complied with lights out, but gave them autonomy. They could keep reading, they could keep writing a letter, they could sew, they could do whatever they want. And that just reduced their mental stress. And that was so important to our success, little things like that. Just want to tell you some of the National Healthcare for the Homeless Council members in Chicago. Heartland Health Outreach is a large healthcare for the homeless program. Lawndale Christian Health Center, which I see is on your, one of their doctors is on your schedule for tomorrow. A great organization, Christian-based, faith-based, really active in their community. Not a health center per se, but really a very important member of ours in Chicago, the Night Ministry. And recently, Cook County Health has been working a lot in the area of homelessness, and we are working with them as well. I want to say a word about medical respite. Our main organizations that we support are health centers, healthcare for the homeless programs, and medical respite programs. And what medical respite is, in a word, or in a few words, one definition, it is for people experiencing homelessness who are not, do not have a clinical reason to continue to stay in a hospital. But the hospital does not have a safe place to discharge them where they can recover, where they can safely recover. So in the absence of medical respite, what happens is they stay in the hospital for a lot longer than they need to, which is very expensive. And also it's not good for the person. We've got a lot of infections in a hospital. And, or they're sent back to their shelter, which is not really equipped to deal with their condition, or their friend's couch, or in some cases back to the streets. When that happens, the person will all too often, their health will deteriorate back in the emergency room, back in the hospital bed with more complications at greater cost. And it just, instead of healing, it makes things worse for them. So medical respite helps to break that cycle. There are about 120 programs across the country, and we are really interested in helping to expand medical respite. So it's generally for short-term issues that can be healed within a relatively brief period of time, usually no more than 3 months. In general, there are always exceptions, but the idea is to recuperate, recover, and then get back. You have an excellent medical respite program in Chicago, the Boulevard, plus Cook County is just starting one, which came about as a result of COVID. And I will say COVID has really made many cities around the country more interested in how can they meet the health needs of their neighbors without homes. And they're looking at medical respite as a model. We got so many requests from people who are not health centers that we created in July of 2020, the National Institute for Medical Respite Care. The resources give you that website as well as the council's website. but we're just really looking to expand medical respite because we know it can help save lives and can improve health of people without homes. I want to talk about a few minutes about the causes of homelessness. And we're going to talk about systemic racism and homelessness. And I'm going to focus on three systems quickly: our housing system, our education system, and our criminal justice system. But I'm only focusing on three, but I really want to, a quote from my mentor, Susan Nybacher, who was a founder of my previous agency, Care for the Homeless, and a founder of the council where I now work. Is that homelessness is the result of almost every system in society. It's the result of the failure of almost every system in society. Think about it, in the richest country on earth, to have 580,000 people on one night, more than 1 million people, 1.5 million at least, in the course of a year experiencing homelessness means something has gone wrong with our system. We don't see those kinds of numbers in other countries that are not as rich as we are. So one of the key things with the federal housing policy, and James mentioned redlining, so I won't talk about that, but what we need to understand is that it was federal policy, not just the practice of banks, federal policy, federal laws that created segregation, that created wealth through home ownership for some and excluded for some based on race. So the Federal Housing Administration is the main underwriter and guarantor for all bank loans. Without that, banks will be much more reluctant to offer bank loans for mortgages, or they would charge a much higher interest rate. But the government is saying, we will back you when you put these loans. So from the very beginning, the FHA and the VA for veterans said, we will not give loans for home ownerships to anyone who is not white. So African Americans were excluded from this by law. Later, in the name of harmonious communities, they said, we will lend to African Americans, but only if they're moving into a predominantly Black neighborhood. So here is where the fallacy of race neutral. Their argument was, well, we don't want to be engaged in social engineering and start desegregating communities. So it seemed like it was race neutral, but what it did was it amplified, it set in stone and then amplified the existing racist structures. And this is a beginning, especially in the post-war period, 1940s, 1950s, when there was just a huge surge of people moving into private homes, home ownership, creating whole suburbs out of farmlands. The federal government, by their laws, said, some neighborhoods were integrated, but they would not allow any African American to move into that neighborhood with a home, so that those became white, and African Americans were left where they were, and cities with redlining and so forth, and so we had some population that had access to creating wealth for their families, entree into the middle class, home equity to send their kids to college, home equity to give their kids a down payment on a house, and some were not, based on race. And so you had some communities that had wealthier and they were owning homes and building wealth. Others had to be relegated to renting. And restrictive covenants were FHA and VA said they would not give any loan unless they had a restrictive covenant in it. Restrictive covenant were part of the deeds that conveyed ownership. That said, you cannot let any person live in your house who is not white unless they are a domestic servant. And when you sell your house, you cannot sell it to anyone who is not white, and you have to keep this deed, this clause in the deed. So even now, there are many deeds from way back, not even way back, 40, 50 years, that have these restrictive covenants in them. They're unenforceable now because they are illegal, but they are still there. So this is not something that's way back. When we think about Jim Crow and slavery, is way back. I'm getting up there, but I'm really not that old. But I was born in a segregated hospital in North Carolina. My sisters, who are older than I am, remember going to segregated schools, separate water fountains and all. When I was a toddler, I was taken to New York. So that's where I grew up. So I did not have that same experience. But this is not ancient history. This is really, really very much where we are today. So I just want to point out, when we talk about creating segregated communities, creating wealth, allowing some to create wealth and some not. My father fought in World War II, African American, came back and was not allowed to buy a house under the VA, though his white fellow servicemen were. So went to a seminar a few years ago here in Nashville. Melanie Crowley is a lawyer. She gave and she made this statement. I went up to her afterwards and said, what you said is right, but it's not complete. And so my addition were that Blacks were excluded from the largest government subsidized wealth creation program in history. And because African Americans paid taxes, they helped to fund the program from which they were unconstitutionally excluded. So we have this wealth gap, largely based on home ownership, on segregation. And one researcher at HUD several years ago found that segregation in and of itself is a driver of homelessness among African Americans. Going to look at a few charts, not going to pay too much attention to the numbers, but just the trends. So what this chart is, it's showing the amount of federal support for to make housing affordable. So Section 8 vouchers, Public Housing Authority funding for the projects, and have safe housing for poor people, that they can have a safe place to live, make housing affordable. So we see the main thing is to see from 1979 to 1982, it dropped by 77%, and it still stayed low. The 2-year spike you see is 2009 and 2010 from the fiscal meltdown of 2008 and 2009. So the stimulus dollars came like a year later, and then it went back down to a low level. Right now, the HUD budget is about $50 billion, a little bit less. The National Low Income Housing Coalition calculated that if we were to have funding at the 1979 level in today's dollars, it should be 125 billion. So way to look at this, except for 2 years, for the last 40 years, we have been underfunding making housing affordable for poor people by the tune of $75 billion a year. And in the early 1980s was when homelessness exploded. We did not have mass homelessness until the early 1980s. I remember growing up in New York in a poor neighborhood. We had a lot of poverty, but we didn't have homelessness. And now my neighborhood where my mother lived, where I grew up, is gentrified. It's a wealthy neighborhood, but the last time I went there and visited, got off the subway, there were homeless people. It is a matter of our public policy. We have made a whole-scale retreat in housing affordable for poor people. This is a public policy choice that has created homelessness at this level that we see today. This is the same kind of thing. You see the red line, the drop. This is instead of dollars, it's in percent of GDP. So we see we are devoting much less percentage of our wealth to making housing affordable for poor people. This is the same kind of thing, but note the black one is our expenditure to make housing affordable. The red line is our federal tax expenditure for home ownership, to promote home ownership. So whereas before we said we have a moral commitment to help poor people have a place to live, more than to ensure that people have a private home or get government help to get a private home, besides the mortgage backing, that has been reversed. So it's just ridiculous. So I gave a lecture using this slide in Orange County, California, about 3 years ago, one of the wealthiest counties in the country. And I start off by saying I grew up in subsidized housing in Brooklyn, and how many people have grown up in subsidized housing? Basically, no one raised their hands. By the end of my talk, when I got to the slide, I said, how many people live in a private house? How many people claim the mortgage interest deduction on their taxes? Everybody raise their hand. That is a housing subsidy. And this is the most ineffective housing subsidy that there is. It does almost nothing to ensure that people have housing. What it does is say whether you can afford to buy a bigger house or a smaller house. And in general, the bigger the house you can afford to buy, the wealthier you are. Therefore, more of the subsidy is going to the wealthier than who don't really need it, than those who are poorer. It's estimated that 80% of the mortgage interest tax deduction goes to the wealthiest part of it, goes to the top 10% of income earners. So we have created mass homelessness, and so we're paying a lot to subsidize housing, but we're doing it to subsidize the wealthier and not the poorer. This is a moral issue. This is a public policy issue, what's being done in our name. I'll move very quickly over to other things. Public education system is supposed to be the great leveler. And this seems to be race neutral. You know, we're just going to do public education. Everyone can have equal opportunity. But the way we choose to finance public education, by and large, by local property taxes, exacerbates built-in inequities. And this study 2 years ago by Ed Build showed what we would expect. Wealthier communities will spend more on theirs than poorer communities. So instead of leveling the playing field, it's further tilting the playing field. And if we really want it to be equitable, if we really want it to be fair, give everyone an equal shot in life, or we would spend more on the students who are poor, who don't have the advantages that their families, that wealthier families can give them. But we do the opposite. And given the fact that where you live, based on past hit practices, policies, and current practices, largely determined, correlated with wealth, with race, we see that poor students will tend to be Black, richer students, wealthier students tend to be whiter. And so we're building, these systems are exacerbating structural racism. Next to the last system is our criminal justice system. So this slide shows that on the left, that African Americans and whites use marijuana usage at roughly the same rate. And this is US government statistics from the Substance Abuse and Mental Health Services Administration, SAMHSA, roughly the same rate. But the chance of getting arrested for marijuana possession are more than three times greater if you are African American than if you are white. Why? It's not because of usage. It's not because of possession. It's because of police practices. Who is more likely to get stopped? In what neighborhoods are you going to be stopped and frisked? Which car is going to be stopped and then be more likely to be searched? It's about structural practices from policing. Almost nothing has a greater impact on your life, especially when you're young, than involvement in the criminal justice system, going to jail. And 80% of those in jail are for drug offenses. And we see many the usage for many of the drugs are about the same for Black and white. And I'm saying Black and white, but that's shorthand for people of color and other races and ethnicities as well. But your chance of going to prison, even though in general the crime rates are the same, is about 5 times greater if you are Black than if you're white. And especially when you're younger, when you have your whole life ahead of you, and this can impact you greater. 18 to 19, 12.7 times greater, and 20 to 24, 8 times greater. So these things, we say, you break the law, you're going to get caught, you're going to go to jail, it's equal. No, it's not equal. And it varies by race. And these are some of the systemic drivers of homelessness. If you're going to be going to a school that's poorly funded, if you're going to be imprisoned, more likely to be in prison for doing the same thing, you have less opportunities. When you come out of jail, depending upon your drug offense, you cannot go live in the public housing projects. That's against the law. Depending on the or it's up, and sometimes it's up to the local housing authority of whether they can exclude you or not. But so we are doing things that are driving homelessness, and it varies by race. I'm going to stop here and just invite you to follow us on social media, the National Healthcare for the Homeless Council, the National Institute for Medical Respite Care, and I'll invite you to get in contact with me. Follow me on Twitter. My email is there, and I really thank you for this time, and I welcome questions.
Thank you so much, Mr. Wantz. That was really, really good.
Oh, and please call me Bobby.
Thank you, Bobby. But yeah, so we have a couple of pre-prepared questions for you, and then I also believe that we've had some questions in the chat already. If you have more questions, everybody, please feel free to send them in. We'll try to get to as many as we can in the next 20 minutes or so. So one of the first questions I'd like to ask is to do with COVID and how it's been impacting housing insecurity. What do you see as the long-term impacts of COVID-19 on housing insecurity and homelessness?
You know, that's a great question, and it's really hard to say, but because it depends what choices we make as a society. So we have seen how, because of the economic downturn, different your exposure to COVID varied, and the chance of losing your job and therefore your housing varied by race. If you're poorer, you're much more likely to be renting and be at risk of not paying rent. Fortunately, and the CDC stepped in, and just think about, we're seeing that housing is healthcare in more than we've ever seen it before. The premier public health agency of the country stepped in and said, in a pandemic, it's bad for public health for people to be evicted. Once you are evicted, so much can go wrong in your life. It's hard to get back one. It's hard to keep your job. It's hard to stay in school if you're a college student. So much can go wrong. You can't stay healthy. So they said, no, we're going to put a moratorium on evictions. I will say this administration is the first one that said in their campaign platform, so that's not the same thing as doing it, but they're the first ones who ever said, we want to fund housing vouchers for everyone that qualifies. Right now, because we set the budget, think about it, we cut it by 77%, we haven't gone back. Right now, only 1 out of 4 households that qualifies for Section 8 voucher or other housing subsidy based upon their low income gets it. So the first time they said, we want to make sure everyone who qualifies gets it. That would be a game changer if that happens. But we don't know. If that doesn't happen, then we will see more housing instability in the short term because of the economic downturn and people losing their jobs. Yes, there's a moratorium, but that doesn't, people have still been evicted, and it could just be holding off until the moratorium is lifted, how many people will be able to stay in their homes. So it's really up to, I say us because we are a democracy and people are acting in our name. We elect them. We need to make our voices heard. So it depends on the choices that we make or that we allow the elected officials to make. Obviously, I feel housing is a human right. So we, as the richest country on earth, can provide to ensure people have a basic minimum housing so that they can be stable and they can have a basic platform and a fair shot at life. We can afford to do that. We really can. It's a matter of will we do that?
Yeah, that's really good. Thank you so much. That's a very thorough answer. I'll go now to one of the questions from the chat. Why are more men than women experiencing homelessness? Does it have to do with resources available to women versus men?
No, that's a great question. I think one of the big things, there are a number of reasons, why people hypothesize. No one really knows for sure. One of the reasons is the criminal involvement with the criminal justice system. I would see guys when I was at the rescue mission come straight from prison, be let off, and come straight to the and be the mission was their discharge plan. And men are greatly outpopulate women in prisons, so that could be one driver. There is a theory that people are more reluctant to turn out a family member who is a female than they are a male. Men, you know, if you can't make it, get out. You'll figure it out. Women, they may be more protective. We do know of the women who are experiencing homelessness, they seem to have greater degree of mental illness or severity of mental illness than the men who are homeless. They are still extremely needy. They are subject to incredible violence on the streets and assault, sexual assault. It's heartbreaking. So they may be smaller in number, but their needs are just as great.
Thank you. Yeah, that's really good. And we actually have quite a few questions in the chat. So I might keep on going with a couple of those. So the next question would be, could you comment on what you would like to emphasize in your service on the Biden-Harris administration COVID-19 Health Equity Task Force as it relates to healthcare and housings for persons experiencing homelessness?
Sure. Well, there are a number of things. One of them is that, well, part of our emphasis is data. So how can we know we have equity if we're not if we're not measuring it? So I really am arguing that we should be doing all we can to have housing status collected at every turn, so we can see what's the impact of COVID on people experiencing homelessness? What is the impact on our efforts to address those concerns? So one is collecting housing status data is one of them. Another one, when we are looking at vaccines, my biggest thing has been in the early part of our service, when different groups were prioritized, politics at the state level overruled science, and it drove me crazy. Part of my training is as an epidemiologist. We want to look at the data. We want that to inform us. So the CDC used a social vulnerability index, which was recommended by the National Academies of Sciences, Engineering, and Medicine. And it looked at different factors, how many people are in your household, do you take public transportation to work, to get an estimate of your risk. And they said we should use this vulnerability index to determine which groups should be the first ones to get the vaccine, with the understanding the most vulnerable ones are the ones that are most likely to get infected, and then to spread it to others, and also to have poor health outcomes. So you want to give the first vaccines to the most vulnerable. People experiencing homelessness and prisoners, according to the CDC, were in phases 1B and 1C. Many states said, no, we're not going to put them there. We're going to put them way down the list, not for science, but for politics. People are saying, what? You're going to give a person experiencing homelessness before you give it to my grandma? Well, your grandmother may be living in a private home, driving a car wherever she goes. She's not in contact with other people. This was based on risk, but local politics overruled science. And that wherever politics overrules science, the politically weak are going to be the ones that suffer, and inequity will thrive. So that is one of the things that I'm still fighting, that battle. Because even though now there's supposedly enough supply, we believe there will be enough supply for everyone. Those forces that drove inequity or fought for inequity will still keep fighting. So where they put testing sites, they may not want to put it in poorer neighborhoods. They may want to make sure it's in wealthier neighborhoods. So there's a lot of still to play. I'll just give two examples of how politics has overruled science, and it's driving inequity. The state of Michigan, one of their legislatures passed a bill, didn't pass because it had to pass both, that forbid the use of the social vulnerability index, because it said that Detroit, a mostly Black city, should be an area where should get it first. So they tried to pass a law that said they couldn't do it. Early in the pandemic, Dallas said, we're going to put our first 10 mass vaccination sites in the zip codes that are hardest hit by COVID, that have the highest COVID rates. The state of Texas said if they do that, they were going to withhold all of their vaccines. So then the city council recanted and said, okay, we won't do that. So you can see how, to my eyes, to many people's eyes, this is inequitable. It's driven by race, it's driven by class, it's driven by income. And it is, I am a Christian, so I'll say it's ungodly and unacceptable, and we need to stand against it.
Yeah, that's really good. I mean, and very moving. Yeah, so there's a lot of questions coming in. We have 8 minutes left. I want to make sure that we hit as many as we can. So
in other words, be short, Bobby. Okay, I will.
We appreciate the long answers. So one question is, how do we know that the numbers of homeless are accurate, even assuming that we can agree on the definition? I mean, one of the things that this conference is about is reframing homelessness. So how do we know that the numbers are correct?
Well, it's really hard. We can be pretty sure with those in shelters because it's easy to count people in shelters. And large cities have good systems to count the numbers in shelters. It's a lot harder when you're counting those who are unsheltered because you're going to miss them. I do outreach with the local ministry here in Nashville, and I'm sure we're going to some encampments that the city government doesn't know. People move around. So when you do the count, it's hard. But the important thing about using the count, and again, it's only a point in time, is you use it consistently, you can see what the trend data is. So you may not know exactly the number, but you can see is it getting worse or not with some degree of confidence.
Yeah, thank you. So what are some resources available for people who are experiencing homelessness or are at risk of that? And how can the audience members, how can we direct people to such resources?
Well, I think you guys know the scene in Chicago better than I do, but I do mention those who are Healthcare for the Homeless, National Healthcare for the Homeless Council members, really try to provide comprehensive services. Heartland Health Alliance is a huge organization that has a Healthcare for the Homeless program. They have they do tremendous work. I went to visit them a couple years ago. They work with refugees. They work with a number of areas, including people experiencing homelessness. Lawndale Christian Health Center, which will have a representative on tomorrow. The Night Ministry in Chicago does excellent work with reaching out to those on the streets. The best way is to link up with those like Windy City Warmth and other organizations that are doing the work instead of trying to reinvent the wheel. But first try to work with existing organizations like yours.
Awesome, thank you. And then we'll have one last question, and then we'll wrap it up for tonight. So how would we achieve national health care that is available to everyone without being exclusive to those who are rich? Yeah,
so the short answer is we need universal health care. And every other industrialized country has achieved this, except we have. And I was reminded, I was looking back to some old pictures and sharing with someone on Facebook. One of my colleagues, we were part of a group, went to Morocco about 7 years ago. And she said, do you remember when we were shocked when Morocco said that they view healthcare as a human right and everybody has health insurance? A poor country. So every other industrialized country does it. I was watching something on PBS yesterday about the Canadian health system, and people say it's socialism. Don't get distracted by labels. It's effective. Everyone gets some basic level of care, and you don't have people falling into poverty, losing their homes because they can't afford cancer treatment like we do here. Um, it will take political will. It will take moving beyond labels and looking under the hood and saying, if these other countries can do it, we can do it if we want to, if we want to. So we need some kind of universal healthcare, whether it's single payer, whether whatever it is. There's lots of different models around the world of how people have done it, but we haven't.
Thank you so much for your answers. And one last thing. So several people have asked if they could get a copy of your slides or your
Yes,
contact
absolutely.
information.
I'll send them to you,
Okay.
and absolutely feel free to share them.
Amazing. Thank you so much.
Thank you.
And then as we close up for tonight, I know that there were a lot of questions that went unanswered, and that's just due to time, I'm afraid. But please keep those for tomorrow morning session. We have another great lineup of people and speakers, and we have a little bit more time. Tomorrow's going to be about an hour and a half. With a 45-minute question and answer time. So please feel free to come back tomorrow. Thank you for coming here tonight, and especially thank you to you, Bobby. I really appreciate you taking the time.
It's an honor. Thank you all.
Awesome. Have a good night, everyone.